Good afternoon. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today for our Medical and Surgical Oncology lecture with the UNC Cancer Network and the Lineberger Comprehensive Cancer Center. Today is May 22nd, 2019. Just a few preliminaries and then we'll meet our speaker and get started. Let's see, if you are having any technical difficulties, call us, 919-445-1000. You may also email us at unccn@unc.edu. We have a great website, unccn.org. You'll find out about past lectures, future lectures, how to take these on your own schedule, all sorts of other things. So please visit our site. We're on YouTube, we're on Facebook, we're on Twitter. And hey, while you're at any one of those, certainly for Twitter or Facebook or LinkedIn, be sure to friend us, be sure to spread the word about these lectures, these free oncology lectures. All right, a few other things and then we'll get started. As always, we will be using Poll Everywhere. This gives you an opportunity to interact with our speaker, gives our speaker an opportunity to find out what you're learning, and then it gives you an opportunity to ask questions at the end. So please utilize Poll Everywhere for this lecture. It's easy, it's anonymous, it's free. All you have to do is, and the easiest way to do this, I think, is to just go to any web browser. If you have a web browser on a phone, a tablet, a computer, just go to pollev, pollev.com/UNCCN. As the questions are asked, you'll see them pop up and you'll be able to respond to them and then ask your questions at the end. If you would prefer to use the texting capability on a phone, you're welcome to do that as well. In the to field, you'll put in the number 22333, and then in the message field, type in UNCCN. You'll send that. You'll get a reply that says you've joined, and then you can just answer the questions with the corresponding letters and then text in your questions at the end. All right, so without further ado, we would like to meet Dr. Trevor Hackman. Dr. Hackman, welcome. Glad to have you here today.
Thank you for having me.
Absolutely. So let's see, what do we know about you? Fellowship-trained head and neck reconstructive surgeon. Okay. On target so far?
On target so far.
Good, good. Served as faculty in the Department of Otolaryngology since 2009 within the Division of Head and Neck Oncology.
Correct.
Areas of clinical expertise include surgical treatment of benign and malignant head and neck cancers affecting the upper aerodigestive tract, and specialty focuses on transoral robotic surgery, salivary gland diseases, and reconstructive surgery.
Correct.
And research interests in the molecular genomics of head and neck cancers, patient care, quality improvement, and quality of life, and investigational trials studying the role of immunotherapy and surgery in the treatment of head and neck cancer.
Absolutely.
What's one thing we should know about you that's not on that list? Maybe a personal interest or travel interest, something like that.
So I'm not a native North Carolinian. I came down here for college at Davidson, which is where I met my wife.
Oh, great.
And we both love North Carolina so much that that's what brought us back here years later to join practice here.
Great.
And we've been here since.
Great. Well, we're fortunate to have you here. Thank you so much.
Mm-hmm.
Let's take a look at Poll Everywhere.
Sure.
We've got a question. Which one of the following statements about human papillomavirus, HPV, is true? And would that be HPV is the most common sexually transmitted infection, STI, and if you think that's the case, A. 79 million Americans, most in their late teens and early 20s, are infected with HPV. B. HPV can cause several types of cancer, including throat cancer. C or D, all of the above. So A, B, C, or D, please go ahead and answer that. It's anonymous, and we'll come back to that in a moment. We do have some disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults with Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. The speaker, Trevor Hackman, MD, FACS, has no conflict of interest relevant to this presentation. Still good?
Correct.
All right. Let's see how they're doing with our poll. So take just a minute to answer that. Okay.
So maybe I don't need to do this lecture.
Maybe not. I think we've got it covered.
People have it on point already.
Yeah, unfortunately, they won't be able to get that continuing education. And I'm guessing while they got that question, you're going to add a lot to their knowledge.
I hope
this
so.
topic.
I hope so.
All right. So on target so far, the role and importance of HPV infection in head and neck cancer with Dr. Trevor Hackman. I'll turn the controls over to you.
Thank you.
All right. Thanks.
So welcome everyone to this afternoon's lecture. It's a broad topic. I'll try to be as comprehensive as I can and go through an important sort of role between HPV infection and head and neck cancer and sort of target sort of where we are now with this infection and why it's becoming a talking point here on our lecture series. As mentioned before, I do not have any conflict of interest or disclosures. So we have 4 objectives I want to try to get us through today within the next hour or so. And I apologize, we may go over an hour, just so you know. First is to review the epidemiology of HPV infection, understand it a little bit before you get into the cancer part of it, and then sort of identify the epidemiology of HPV-related cancers and how there's that interplay between the two. Discuss some of the impacts that HPV has had on our patient prognosis, our treatment, and even the development or the consideration for personalized therapy. And then sort of differentiate the treatment options, areas of exploration, and possibilities for prevention, which is critical for this disease. So just to get a broad overview of epidemiology of HPV, as was mentioned in the previous poll slide, this is the most common sexually transmitted virus or infection in the U.S. And there's a lot of numbers up on this slide, but the bottom line is that it's prevalent. If you look at 15 to 24-year-old adults, or teenagers, you see about 1,200 people infected per day across the U.S. What we do know is that the risk of infection is significantly correlated to sexual activity. The odds ratio, or the risk of getting an infection, increases with the number of partners. Roughly 80% by CDC estimate of Americans will have some form of an HPV infection in their lifetime. That translates into about 62 million infections overall per year, 26 million Americans potentially even per day obtaining a new active infection, and of those maybe a small subset having the actual HPV P16 variety of the infection. But the most important point on this slide is that the vast majority of individuals will clear this virus spontaneously. And studies were done in the early 2000s, and at that time they polled and tested college students, mostly freshmen and sophomore, and did a prevalence of what was the HPV infection among college students, freshmen and sophomore. They brought those same students back a year later, and roughly 90% of students had spontaneously cleared the infection if they had it before. And of those that retained the infection after that first year, a large percentage of those patients cleared the infection within the second year, leaving only a very, very small subset, less than 0.1%, who actually harbored the infection as carriers longer than 2 years. And this was a study done on college campuses probably about 15 to 20 years ago. Whether that data or that epidemiology has changed, probably, but the main lesson from that is that the immunologic response, or your ability for your immune system to clear this virus, is actually pretty prevalent, which is why we see such a large number of people having the infection, but very few actually having cancers related to it. That being said, there is a role of HPV virus and cancer. It is known as an oncogene. It's a DNA virus, and there are a multitude of subtypes of HPV. There are low-risk subtypes that we've identified for years now, and these are HPV 6 and 11. They're responsible for recurrent papillomas of the aerodigestive tract, the throat, as well as benign warts. And then there are the high-risk oncogenes. HPV 16 and 18 were the first identified and the most prevalent. These were initially identified and discussed within the confines of cervical cancer. As many people likely know, cervical cancer at this point in this day and age is primarily thought to be an HPV-driven disease, where testing for HPV has supplanted the normal pap smear from a standpoint of deciding whether somebody's at risk for cervical cancer. Anogenital cancer, also high rate of HPV. But what we have seen over the last 2 decades is that oropharyngeal cancer, and this is cancer of the tonsil, back of the tongue, cancer of the throat, has had an increasing incidence of HPV-induced cancer. Roughly 20% to now up to 70% and maybe even higher in certain areas of the oropharyngeal cancers we see are HPV-driven. The most prevalent strain of this is HPV 16. If you look in the literature, there are roughly 9 proven strains that have cancer-causing capabilities and maybe another 6 or so that potentially may have cancer-causing abilities. So anywhere from 9 to 15 strains that may have cancer possibilities from a standpoint of a viral infection. There's 2 proteins that we talk about, and they'll be mentioned in the slide. E6 and E7, these are drivers of the cancer pathway for HPV. They target 2 areas in our body, P53 and the retinoblastoma functions, which are thought to be tumor suppressive functions. And the mechanism behind HPV, unlike smoking and drinking, which is thought to be more of a carcinogen, a mutation, a change in these structures, is that we're actually having suppression of them by HPV. And that suppression, as opposed to mutation, is one of the big reasons why HPV-induced cancers behave differently. When you look at the mechanism of action, this is what I just alluded to, HPV-positive patients tend to have blockade or degradation of P53, downregulation of retinoblastoma, and an upregulation of the protein P16, an overexpression, if you will. And that will come up later in the talk. Whereas if you look at our historic smoking, drinking population, that is typically an HPV negative disease, and that's thought to be primarily due to mutations in the genome. Mutations that change it from being a normal protein that's being blocked to being an abnormal structure. When you look at oropharyngeal cancer, we're going to discuss a little bit now the epidemiology of this, because of our head and neck malignancies, this is the one most strongly linked to HPV. Head and neck cancer overall is probably the 6th leading cause of cancer mortality at this point. Close to 650,000 cases per year, 300,000 deaths per year. Of that, if you look at the microcosm of oropharyngeal, laryngeal, oral cavity cases, new cases every year, it's roughly about 65,000. If you then go to a further subset analysis, the number of new HPV-positive oropharyngeal cancers is roughly 18,000 cases per year. And you may say, well, that's a small number. And it is compared to the overall population and to the overall cancer population. But what is interesting is that while it's a small number, it's been increasing at 3% per year nearly every year since 2000. And it's that rate of growth or rate of increased incidence that has caused a lot of attention, because many of our other cancers are actually declining, and yet HPV-positive oropharyngeal cancer is on the rise. And if you look at this slide, and this is a slide from the CDC, what I have highlighted here is that oropharyngeal cancer is now the single leading HPV-positive cancer reported, higher than cervical cancer. And there are likely multiple factors related to that. Number one, under-recognized is the impact that HPV has had on oropharyngeal cancer in the general public. And number two, cervical cancer has been recognized for a while, and vaccinations have been done, and there's screening, and there is much more attention to prevention. We don't have that same attention to prevention yet in oropharyngeal cancer, but it now is the leading cause of HPV malignancy here in the U.S. I think we have our first poll everywhere, so we'll give you a few moments to look at the questions here. Number one, is the infection difficult to clear? 2, does this infection uniformly lead to cancer? And then works by mutating P53, infection is correlated with lifetime partners.
All right, and take just maybe 10, 15 more seconds to respond. Again, this is all anonymous, so feel free to make your best guess on this based on the information you have. Dr. Hackman, how are they doing?
overall, we're doing fantastic. So yes, infection does correlate with the number of lifetime partners, and that is important, and that'll come up later in the talk. Unlike HPV negative or smoking or tobacco-induced head and neck cancer, HPV suppresses p53 but doesn't mutate it. And this is important because it aligns with why this cancer is more readily responsive to therapy. All right, so we'll move on. So to give sort of an anatomic roadmap as to where we're going, this is a view from one of the anatomic pathology books. Netterville is a common book that shows what we call the sagittal split view of the internal aspect of the head and neck. And you'll see the nose in the front here, the spinal column in the back, the oral tongue here split down the midline, and the separation between what we call the oral cavity, which is anterior, and the oropharynx, which is back here, posterior. And the oropharynx is unique in a couple ways. Number one, it houses lymphoid tissue on the surface, and that would be what people recognize as the palatine tonsils, which are what people can think about when you think about a tonsillectomy. But there's also a continuation of these palatine tonsils onto the back of the tongue in an area called the base of tongue, and this houses lingual tonsil tissue that is identical to the palatine tonsil tissue, and oftentimes there's a direct continuum of this tissue from right side across the back of the tongue to the left side, and that's called Waldeyer's ring. And in fact, if you look in children, they oftentimes have lymphoid tissue up here known as adenoid tissue. Most of the time that resolves and resorbs away by the time you're a teenager or a young adult, and you're left with the lymphoid tissue back here in the tonsil and base tongue, and the fact that there's lymphoid tissue there is important. When we look at cancer incidence, and again, we alluded to this earlier, the majority of head and neck cancers that we take care of, if you look from the mid-'80s to now, have been declining. And this looks at the incidence is going down. This is likely thought to be due to efforts with tobacco cessation. Less smoking, less head and neck cancer in general. But what's interesting is that if you look at the tongue, which includes tongue, base of tongue, and tonsil, there's been a sharp, steady increase since the late 90s, early 2000s. When you further bisect, get the other populations out, and you just look at this population, you see that it's oropharynx and tonsil where there's been a steady rise since the late 90s, early 2000s. Now, some of these oropharyngeal cancers are smoking-induced. Some are virally induced. When you further break this down, you'll see this divide where in the red line you have the classic HPV negative smoking cancers. They are steadily declining since the mid to early 80s. Yet there's been a precipitous increase in HPV positive cancers, so much so that it counterbalances and overwhelms the decrease we're having in smoking-related cancers. And now this is why HPV has become the leading cause of tonsil and base of tongue cancer. The other thing too about this cancer is that the demographics of who it affects is different. Right now, the predominance of male to female is roughly 3 to 4-fold male to female ratio, meaning for every 1 female, roughly 4 men can be affected with this cancer. It typically affects, as we mentioned, a non-smoking, non-drinking population, although there can be some crossover. You see this in younger ages, and this is critical to a lot of the considerations we have for therapy, because we're not talking about patients who are 65, 75-year-old smoking patients develop cancer. We're talking about younger patients, 30s to 50s, some even younger in their 20s, developing these malignancies at a young age, which brings up issues with both treatment, entering back into the workforce, and survivorship for these patients developing cancer at such a young age. Typically, it's seen in a higher socioeconomic status, higher levels of education, which is not true of many of our other cancers. It's less frequent in non-Caucasian populations, but still prevalent. And as I mentioned earlier on the slide, it seems to have a predilection for the lymphoid tissue in the throat as opposed to the normal mucosal lining. Furthermore, a few folks have looked into, well, why is it that men are getting more oropharyngeal HPV-induced malignancy than women? What's the theory behind it? We don't have a definitive answer, but there have been a few theories posed, one by Gillison et al., where the concept is that, as we mentioned earlier in the talk, many people clear HPV infection within a year. The ability to clear it is dependent upon your body developing an immune response to the virus. The theory is that for women, there is earlier and more prominent mucosal contact in the vaginal mucosa to the virus, and therefore it is presented to the immune system earlier, so you can have earlier seroconversion, development of immune response with less partners. Whereas men, there's a decrease in mucosal contact, and because of that decrease in mucosal contact, it requires multiple partners to get there, and because of that decreased contact, it allows the virus to integrate and stay before the immune system can recognize that it is a virus and develop antibodies to eradicate it. Again, this is not proof, but this is a sort of proposed theory, if you will, as to why there may be this predilection for the male population. When you break it down across this slide for different races, you see that the male to female ratio tends to hold true across different races, but there still is a greater prevalence of this malignancy in the Caucasian population, and this is data from 2011 to 2015 from the CDC. This clinical presentation slide, the keys to look at here are that the presentation is different. Like we talked about, if you look at the right-hand side, the HPV positive compared to the HPV negative, non-smoker versus smoker, usually younger male, multiple partners, as opposed to lower socioeconomic status, lower education. But the other thing to really point out is this disparity here. As mentioned earlier, the virus seems to have a predilection for lymphoid tissue, the tonsil, the base tongue, not normal mucosa. Whereas if you look at the HPV negative group, they will infect, or they will arise from mutations from tobacco and alcohol in the normal mucosa, and so the subsites that are involved are different. And this is important to presentation and treatment. You can have tumors arise on the pharyngeal wall, on the soft palate. They can also arise in the tonsil and base of tongue, but they can have these mucosal origins as well, whereas the HPV positive population seems to be limited to the lymphoid tissue. In addition, because it arises, the HPV negative populations have cancers that arise from tobacco and alcohol on any mucosal surface, those areas are more sensate, they tend to ulcerate, and there is a greater predilection of those patients coming in with sore throat, trouble swallowing, ear pain as symptoms. Whereas in the HPV negative population, you're actually seeing no real symptoms. The main reason somebody comes in to see us with an HPV positive cancer is because of a painless neck mass. There's no red flag symptom because the lesions are typically very small, they spread to lymph nodes early, and they're typically in areas that are fairly insensate, and so you don't have these trigger symptoms that you do with oral cavity and HPV negative oropharynx. So we have now our next polling question, which is, does HPV positive oropharyngeal cancer affect more women than men? Is the incidence increasing each year? Is the prognosis independent of alcohol? And is there a similar demographic to oral cavity?
All right, and thank you to those of you who've already taken time to answer the poll.
Yeah.
How are they doing?
Again, doing extremely well. You're correct. Incidence is increasing every year, and that's the critical point, is that we have now a cancer population, which we know has a viral trigger, that's increasing every year, and this is a cancer population that we have the power to get control of.
All right, thank you.
So going back to clinical presentation, again, many people we see, it's because of a painless neck mass. Rarely there might be some symptoms, but the lesions are small, they don't trigger nerve endings because they don't ulcerate, and so you typically don't see the classic symptoms you see in our other patients. Lymphoid primary is the main reason why. Because of this, we have quite a few patients who don't have an obvious primary, and this becomes an issue for planning treatment. PET-CT scans have played a large role in helping us to further map these patients and give them a full view of what their cancer might be, including identifying the primary site. And the role of identifying the virus and its role in the cancer is also critical in making our treatment decisions. So here's an example of somebody I see in clinic. You're going to have two pictures here. On the left, you have what we call a flexible laryngoscopy view. So this is, we're putting a camera down somebody's nose. We take a look to the back of the throat, flex the camera down, and this gives us a chance to look at the back of the throat with sort of high definition. In the middle of this frame is the epiglottis. If you were to lean over the epiglottic edge, just off the precipice there, you'd see the true vocal folds, which close and open when you talk and when you breathe. This epiglottis acts like a trap door so that when you swallow, it will tilt down. It covers the larynx so that when you swallow, food diverts around the epiglottis down to your esophagus and you don't aspirate. So that's what that structure is. It's called the epiglottis. It's the beginning of the voice box area. In front of that is the vallecula, and then here is that lymphoid tissue I was talking about in the base of tongue. This looks very similar to tonsil tissue because it is tonsil tissue. And you can even see there's these little crypts in the back of the tongue, just like you have in your tonsils. And these crypts exist because by having all these little pockets, the relative surface area that mass now has to inform immune responses to infection is greater. That's why we have crypts and valleys in the tonsils and the base tongue. It increases surface area for contact and for generation of immune response when you're younger. This base of tongue lymphoid tissue is pretty normal. What's not normal is this subtle little lesion here. Now on the screen, it doesn't look subtle. In real life, this is probably about 5 millimeters in size. And it's causing no symptoms. And frankly, unless you know to look for it, you may not see it. So this is that small little tumor that I'm seeing in clinic in somebody who's sent to me with a neck mass on the right side with an unknown primary. To the right of our screen is a PET-CT. And on the PET-CT, you'll see bright spot here and an asymmetric bright spot here. So there are a few things about PET-CTs. Get rid of a few misnomers. PET-CTs are not everything. They don't prognosticate. They can't diagnose disease. They are another tool that we use to help with treatment. The way PET-CTs work is that you are injecting a radio-labeled sugar through an IV that courses through your body. That tagged sugar is what the PET-CT scanner is looking for. And so you're looking for areas of sugar consumption. On a PET-CT, the brain will light up like a Christmas tree because your brain is active all the time, which is why PET-CTs are not very good for looking at brain lesions because they can't see the lesion behind all the activity of brain function. The heart also is pumping, and so you'll see activity in the heart. If you did a PET-CT somehow on a treadmill, you'd have your legs light up because of activity. But the rest of your body is relatively quiescent. The thought process is cancers metabolize at a higher rate, and because of that metabolism, they burn more sugar. Therefore, areas that have high areas of sugar consumption, bright signal, are thought to be potentially at risk for cancer. It should be said that in a PET-CT scan, you excrete a lot of the majority of the PET-CT radiolabeled sugar through your kidneys, so your kidneys will light up as well as your bladder because you're getting rid of the substance at the same time while the scan is being processed. But in this particular image, you'll see that there should be no reason for this lymph node to light up. So that's pretty definitive. You'll notice, though, that in the back of the tongue, there actually is activity on both sides. And there's a reason. This tongue base has little areas, little mini pockets of infection. It's not causing the patient symptoms, but it's causing an inflammatory response. And with an inflammatory response comes recruiter cells, white blood cells to try and fight off constant inflammation. Those cells need energy. They need sugar. They burn sugar. So areas of infection also light up on a PET scan. So a negative PET scan is helpful from a standpoint is that we can't see anything, but a positive PET scan has to be interpreted with the likelihood of that truly representing disease, or are we looking at infection? And then the last thing is, A negative PET scan does not mean that you're cured of disease. I get this question a lot. 3 months after treatment, they get their negative PET. Am I cured, doctor? And the answer is we don't know. Within our population of cancer patients, what we do know is that if you make it to 5 years and you haven't shown signs of recurrence, then we were successful on day 1. But up until then, we just don't know. And even a PET scan, which is great technology, can't see individual cells. The analogy I give to a lot of my patients is, if you were at night putting your lights on in your house, every light in your house, people from the NASA space station would not know the lights were on in your house. But if the entire southeast corridor simultaneously clicked on all the lights at the same time, we'd probably see a flicker or a spot. That's PET-CT. There are, in this particular area, hundreds of millions of cells conglomerating together to create a signal. It takes one to have recurrence, but it takes hundreds of million conglomerated together to get a large enough consumption of sugar to create a large enough signal. And that's why cure of cancer is a time-related follow-up and not necessarily a scan-related phenomenon. So the HPV Diagnostic Dilemma, we've tipped on this already. It's a younger, otherwise healthy population. It's not your stereotypical cancer population. So unfortunately, that means that both patients and providers have a lower index of suspicion, even when somebody comes in with a neck mass, and they usually will get the cursory dose of antibiotics, even though the patient has no signs or symptoms of an infection. This leads to delay in presentation and delay in referral. In addition, they typically present with a neck mass, not because of the primary site. This creates a little bit of a quandary, because if you look at most of our cancer staging systems, up until very recently, the presence of a lymph node made you a stage 3 patient. The presence of 2 lymph nodes made you a stage 4 patient, which lung metastasis also makes you stage 4. And so it's very, very difficult to wrap your head around a cancer population that does so well, but then we're still qualifying them as stage 3 and stage 4 because they almost always present with lymph nodes. And that caused a lot of discussion amongst national cancer groups about, should we be thinking about this population differently? And the answer is we should. In addition to this dilemma is also the elephant in the room, the social dynamics of telling somebody that they have an STD-related cancer, and what that brings up sometimes in the room with patients and spouses and fidelity, and we're going to get into that as well. But the biggest thing is raising awareness, and that's what we're trying to do today. HPV-driven disease is different in many ways. Here's a graph that came from a study roughly about 5 years ago showing this. If you look at the survival curves for an HPV positive patient, it's in the high to mid 90% range. And this goes out more than 6 years. So this is true data of clinical cure. As opposed to our HPV negative patients, it's hovering around 50%. That's a very big difference in talking to a patient about their prognosis when you start treatment of disease. To further sort of break it down, we have 4 graphs here. And this came out of a landmark article in the New England Journal of Medicine in 2010, so almost 10 years ago. And in this article, they looked at HPV positive versus HPV negative disease. And what you see on these top 2 graphs as progression-free survival and overall survival were markedly better in the HPV positive group, and these are standard deviation lines around the mean, than the HPV negative group. Somewhere in the high 80 to 90% range versus down to 50% range. What they looked at down here in the bottom 2 slides, and this alludes to what I mentioned earlier when we were talking about the HPV sort of epidemiology of the virus itself, and how it causes oropharyngeal cancer. You'll remember I mentioned that P16 expression goes up. Well, P16 is a byproduct protein of the HPV-driven process causing the cancer. And what we see is that P16 positivity was even more predictive of a disparity, reducing the hazard ratio for death even more significantly than even the positivity of HPV. And these are 2 different ways these tests are done. One is what's called in situ hybridization, identifying the DNA virus, apologies, and the other is an immunohistochemical stain. But either way, what we have here now is not only evidence that HPV positive patients actually have a different and much better prognosis, but we have a way to find out if they are HPV positive or not, potentially before therapy. In this same article, the question logically came up, well, what happens to those people who are smokers? Because there are some people, and we live in the state of North Carolina, where smoking is still prevalent. And there are people who are younger who still smoke. And they did a subset analysis where they took patients who were positive and negative, and they broke it down between whether they were smokers or not, and whether they smoked for greater than 10-pack years. And so if you smoke for 2 packs a day for 5 years, that's 10-pack years. 1 for 10 years, 10-pack years. And they separated these populations out. And what they were able to show is even a further separation of these curves. So on the top here, this low-risk population, these are HPV-driven cancers in non-smokers. Intermediate risk is a combination of either HPV-positive cancers who are smokers or HPV negatives who are non-smokers. They didn't do as well. And then the lowest curve, apologies, shows you the high-risk population. These are the HPV-negative cancers who are smokers. And now you can really see that we are able to stratify and talk to patients really about their risk profile when they come in before therapy. And again, it also highlights the importance of not smoking, because the smoking population, irrespective of the HPV status, does poorly with treatment. And there's many factors that go into that. And this is sort of a table representation of what I just mentioned, that the low-risk group, if you look at it, the overall survival rates are 93%. Intermediate, 70%. High risk, 46%. And this is stratified by HPV positivity or not, and smoking and how they interplay with each other. So this led to a cancer discussion amongst cancer professionals across the country about how are we going to approach this increasing incident cancer that behaves so differently. Because with an overall survival in the low-risk population, should we really be qualifying them as stage 4? How are we going to really think about them? And so recently, this past year, we have a new staging system just for this cancer because it is so different. We have, as a cancer society, accepted P16 as a surrogate marker for whether a disease is HPV-driven. There's some flaws in this, but it is roughly a very good estimate, and it is a test that can be done at any pathology suite because it just requires immunohistochemistry, and it's affordable. The nodal stage has been reduced or changed, and the overall stage of these patients has reduced and changed. And what that's left us with is now the quandary of, if we are saying that these cancers do so much better, should we be giving them as intensive a therapy as we gave to our historic smoking and drinking cancer patients? Because number one, they may not need it, and number two, these are younger patients, and we still don't know what the long-term survivorship is for 4 to 5 decades after having radiation therapy for a 25-year-old for a tonsil cancer. And so we're having the discussions now of, can we truly de-escalate or reduce therapy toxicities but still maintain control? This blow-up graph is not meant for you to read every detail. What I want you to get is a picture sense. On the left side is the 8th edition. This is the new edition of staging we have. On the right side is the 8th edition, but using the historic criteria for HPV negative. So left side HPV positive, the new staging. Right side is HPV negative staging, and it mirrors very closely the prior staging system. And what you'll notice is there's a lot more going on the right. There's far more breakdown of stages, both, and it's mostly in the nodal stage. On the left side, in the HPV positive group, we've simplified things. And we simplified things to say that you could have 7 lymph nodes clinically in your right neck, and you're HPV driven, and you're considered N1. Whereas in the other side, you'd be considered N2, and that changes you from stage 3 to stage 4 by the old system. pathologically, you have to have more than 4 lymph nodes positive pathologically to even be N2. And in the new staging system for HPV positive cancer, there is no N3. There is no unresectable or high risk nodal disease. But we still see that in the negative population. And this plays out on this next slide. And you'll see what I've highlighted in red. And what I've highlighted is that very quickly on the right, which is table 5, you can see that patients can very quickly escalate from stage 1 to stage 2 to stage 3 and to many differentiations of stage 4. And you'll notice that on that side, as soon as you get a lymph node, you're stage 3. As soon as you get more than 1, you're stage 4. Now come to the other side, you can have a small lesion, or not, we can't find it, a fairly small lesion, less than 2 centimeters, a lesion less than 4 centimeters, and you're still considered stage 1, even if you have lymph nodes involved. That's very different. Stage 1 versus stage 3. You can have a T3 lesion. This is a lesion that's greater than 4 centimeters and have multiple lymph nodes involved, and you're stage 2. Whereas in our old system, you're stage 4A. And these curves and these new strategies of staging patients come out of the curves from those studies back in 2010 that showed, from a survival standpoint, these metrics didn't really drive survival, which is why they're stage 1 and stage 2. What drove survival was advanced T stage, so T4, and lung disease. And you'll notice that you can't be a stage 4 unless you have lung disease. So really, how these populations are treated is different, and so how we assess them is different. So here's our next question. T3 lesions can be stage 1 in HPV positive. They have similar pathologic and clinical staging. You have to do PCR testing to get a diagnosis, and N3 disease is only due to extranodal extension. I'm not going to stump you guys today, am I?
They're doing well.
So we'll let a few more people respond, but you guys are following points, and hopefully you highlighted this. The staging system is different. How we look at these patients is different. How we categorize them is different. And it's intentional, and it's based on data of how people have done over the last few decades in management of these cancers.
Okay. Thanks again for all your responses.
So now let's talk about treatment implications. We've already said, and I'll say it again, it is just different. These patients have a better prognosis overall. Paramount is identifying, can we say that they are HPV-driven diseases? How do we prove that? We've talked about it, HPV testing or P16 testing. And then we have to think about how that impacts counseling and expectations, and then treatment decisions. So the ancillary testing, we've alluded to it already. Imaging, and in the current day and age, a PET-CT scan is considered standard of care for somebody with a known P16 positive neck mass and an unknown primary. That is definitively a standard of care treatment as part of assessing the global state of that patient's health. Historically, CT neck and chest was all that we would need for typical cancer staging. PET-CT was an option, but in the realm of the unknown primary, PET-CT scan does have significant potential value. There's also sometimes the need, though, to establish tissue diagnosis. And so if a PET-CT scan cannot reveal the primary lesion, and my in-office flexible exam can't show the primary lesion, those patients still likely warrant some form of endoscopy or trip to the operating room to find their primary tumor. And here's the main reason why. These cancers are very responsive to therapy. Patients do extremely well. And so we're looking at how can we minimize side effects and toxicity to patients. In the historic unknown primary patient, non-HPV, if we could not find the primary, that patient, if they were receiving radiation therapy and chemotherapy treatment, would have radiation therapy from their nasopharynx, their adenoids, all the way down to their voice box, both sides of the throat. That's extremely morbid. It causes a lot of side effects. It has higher rates of long-term swallowing problems, breathing problems, voicing problems, dry mouth, and need for feeding tubes long term. If we can identify the primary, we are able to shrink the zone that we treat. Now, it's accepted nationally that if you can prove the lymph node is HPV positive by testing, you can assume that the cancer is somewhere in the base of tongue or the tonsil tissues, in that Waldeyer's ring. And so you can already sort of target that therapy a little bit, but if we can show that it's in the tonsil and not the tongue base, not only might we spare some of the internal lining of the throat from getting innocent bystander radiation toxicity, but we can also have a conversation about how much treatment does somebody need? Because in the historic patient who's got an oropharynx primary, many of those patients would get bilateral, both sides, neck radiation therapy. If we can prove the lesions in the tonsil, it's an accepted standard of care for them to have just tonsil and ipsilateral same-sided neck radiation therapy, sparing the majority of the throat and the other neck, which has significant potential benefits from long-term function, especially when you're considering treating a population as young as they are, who will have many decades likely beyond that in which they're in survivorship. Molecular typing is that other part. So as I said, if we can find a way to biopsy and prove causality, or at least association, it allows us to sort of drive patients down the right treatment window. So this is a statement from the American College of Pathology, and this came out in 2017. And pathology has recognized that any tissue that's biopsied from the head and neck should really be screened for P16 status, for HPV status, because it's recognized how big of a driver it is. This is a slide I previously showed. Again, there's a disparity between how people do, whether they're positive or negative, and whether they're P16 positive or negative. The challenge really is P16 positivity is not synonymous with HPV. There are other things that can upregulate the expression of P16 besides HPV by itself. And so some of the challenges are most of the patients behave the same way, but there are a few people who probably are in the wrong category based on these testing. If you look at sort of how you can test for P16, we have a couple of options. You can look for the DNA, and that's the in situ hybridization, and what we call PCR, and that's looking for the virus itself present in the tissues. Can you find signs of virus? On the right-hand side of the screen is P16 overexpression. Is the protein overexpressed because of amplification and transcription? And that's an immunohistochemistry test. And in the middle is your RNA. Is there active RNA transcription happening? That's probably where the gold standard should be, because the presence of DNA virus doesn't mean that you have cancer. The presence of P16 doesn't mean it's HPV driven. But if you can prove that there's HPV RNA transcription happening, the link between causality is much higher. This slide looks a little busy, but I want to go through it slowly. This goes to the point we talked about, that neither HPV testing nor P16 is perfect. They're very good, but they're not perfect. In a study from 2010, they stratified patients into whether they were P16 positive by that protein expression, again, an immunohistochemical stain, which is a stain that pathology can put on the slide and look for whether there's P16 positivity in the cells, and whether they were negative. And they found in their cohort of roughly 239 cases that 3/4 were P16 positive. And so we're going to focus on the left-hand side of the slide now. Of that, 72% were also positive for DNA, but 28% were not. So they further substratified those patients into whether they were PCR positive or whether they were PCR negative. And they found that some of the people who were thought to be HPV negative by the in situ test were actually positive by the PCR. So they found fragments of DNA. So this points to the fact that there may be a lack of sensitivity of in situ hybridization. But there were still roughly 26 patients that were P16 positive, but they were also HPV in situ and PCR negative. So are those tumors truly in those subset, this is the blue group down here, are they truly HPV driven, or are we being fooled? Is this a false positive test up here in this subset? On the same side, if you go to where people are P16 negative, a small percentage of them were actually HPV positive. So what does that mean? Is this a true positive status? Is this just somebody who's a carrier and they've got some HPV? These are the things that we don't know, and this is why the testing, while it is good, and I showed you those curves earlier, how they really separate out in performance, but they're not perfect. So prognosis with HPV. Why do HPV positive patients overall as a group, not everybody, but overall do better? Number one, we hit on this very early on. It's not about mutations. It's about suppressing the tumor suppressing genes. It's about preventing them from acting. And so they harbor fewer genetic alterations. It's more suppressing the normal P53, suppressing the normal retinoblastoma, not morphing it or changing it. They are more radiosensitive. So the apoptotic response, that is your body's, their cells program cell death when they recognize abnormality. Our cells are programmed to die if they sense that they're abnormal. In mutated cancers from smoking and drinking, those mutations make the cells immortal, and even when they're damaged or not normal, they survive. And that is what cancer typically is. In addition, there's this absence of what we call field cancerization. Let me explain this concept. When you're a smoker, you may develop a cancer on the inside of your right cheek or the top of your left tongue. Why is that particular part of your mucosa special? The answer is it's not. What we see in smokers is that if they get one cancer, they are at much higher risk of getting additional cancers down the road. Oral cavity, voice box, lung. And it's this concept of field cancerization where you have mutations happening and damage and repair happening everywhere. And eventually when the damage happens but it can't be repaired and the cell becomes immortal, cancer begins. And so our smoking population, they have insulted their entire aerodigestive tract with the carcinogens in tobacco. Our HPV positive population affects the lymphoid tissue, a very small subset of the actual tissue available to infect within the aerodigestive tract. So because their area that they're involving is smaller and they're not causing mutations, you see a much more targeted population to treat. We talked about the role of an immunologic response. The fact that your immune system can recognize HPV and eradicate it, if there are ways to prime the immune system to recognize HPV-driven cancers, you can actually generate an immunologic response and have your immune system aid in treatment of the cancer. Whereas in our classic smoking and drinking population, the cancers have the ability to evade the immune system. Finally, these patients are younger, have very good performance status, and fewer comorbidities. So they can tolerate the therapies, and they're less likely to have treatment-related significant toxicities that may affect lifespan. There are patients in our smoking and drinking population where it's not the cancer that leads to long-term survival issues, but sometimes the toxicities from the therapy. So treatment options: surgery with adjuvant therapy, radiation therapy plus or minus chemotherapy, and then clinical trial therapy. For the most part, when you think about cancer treatment within the head and neck, there's two pillars. There's surgery and there's radiation. Chemotherapy or immunotherapy has long been thought to be an adjunct primarily to radiation therapy, making the cancers more susceptible to the radiation therapy. But when you think about the primary therapy, it's either surgery or radiation. When we have the opportunity to just use one therapy to lower the side effects, we try to, but sometimes we have to combine them. The clinical trial therapy implies studies that are done here or at other institutions investigating novel ways to think about cancer. And I'm proud to say that here at UNC, we are a leader in that within the field of HPV-related oropharynx cancer. We have to think about treatment choices more than just what's going to give the best survival, because now we're talking about a cancer population where the overall survival is so high. So now we got to think about not only how do we get high survival, but how do we do that and not cause significant morbidity to essentially our workforce population who are younger and may have to live with those morbidities for many, many decades. Again, we have excellent survival outcomes, so the focus now is on morbidity reduction, but doing that without sacrificing the cancer control that we've been able to show we have for this type of cancer on a global scale. The question is, what is morbidity? How do we identify it? How do we measure it? And then how do we compare? And what's that timeline? How long do we follow those patients out? So early stage cancer, as I mentioned, most patients now who are identified by the new staging system are early stage. It's very rare to find an advanced stage HPV positive cancer. And since most of them are early stage, we're trying to treat them like early stage patients, which is, again, a little bit of a challenge because you want to make sure that you're still doing the right thing by these patients and give them long-term the best option for cure, but in the short term not hurting them. So we've tended towards monotherapy, picking surgery or radiation therapy alone if we can for some of these early stage patients. And this has been based on the adjustment to the new staging system. So again, early stage patients. These stage 1, stage 2 are typically lumped together when you evaluate patients. If they're early stage, can we really dial down their therapy and give them less and get them to the same place? It should be noticed that there's a T0 status. And what that means is that we couldn't find the primary tumor, but we proved that there was P16 in the lymph node. And so we treat them as if they're an oropharyngeal primary because we know these primaries can sometimes be so small and that we don't see P16 positive disease originating from other areas in the aerodigestive tract, that there can be an undefined primary and we still stage them. So surgery. Obviously a big interest of mine. I'm a surgeon here at UNC. And I did my fellowship training over a decade ago in transoral surgery. At the time, transoral laser microsurgery. And I now perform that as well as transoral robotic surgery, which many of you may have heard about. Okay, it's not the panacea. It's not a magical surgery. There's not this magical robot that's curing people. Let's get that out there. It is a technique. And the analogy I give to my patients is that if you were going to get your half bath done in your house, you would hire a contractor to come in, pull the sink out, maybe pull the floors up, maybe get the sideboards out, and you would redo the bathroom. You wouldn't take out the load-bearing external walls of your house to access the kitchen from the outside. That would be ridiculous, right? You'd ruin the foundation of your house and the house could collapse. That's the same idea with TORS. We're doing the same surgery, we're doing the same work, but we're going from the inside because there are muscles, cartilage, and structural support elements in your throat and in your neck that are vital to function. As soon as you cut across them, even though you put them back together, they will not work the same way again. And the biggest side effects with surgery in the head and neck area is dysfunction to speech, swallowing, needing tracheostomy tubes. If we can do a transoral surgery, remove the tumor from the inside, but save all the scaffolding, the muscular slings for swallowing, patients recover faster, have less need for G-tube, tracheostomy, and long-term achieve better swallowing. And if they need adjuvant therapy, meaning postoperative radiation therapy, they can tolerate that therapy better. Radiation therapy wasn't a preeminent primary therapy for head and neck cancer in the 1970s and 1980s. The reason radiation therapy gained favor wasn't because surgery didn't work, it was because these open procedures where we would split the head and the mouth apart and put them back together left patients morbid with trachs and G-tubes and then getting radiation therapy. And the question became, can we avoid all that stuff and maybe just radiate instead? Because this is a lot to take care of. That's kind of what spawned the role of radiation therapy really as a primary treatment of head and neck cancer. Transoral surgery pushes back a little bit and says, well, maybe we can do it, maximize tumor removal, but minimize damage and harm to the normal structures around. And if we can remove tumor and get negative margins, can we limit whether patients need radiation therapy at all, or can we limit the field that they need? So this is a picture of prior to a transoral case. You'll see that epiglottis I talked about before. There it is now. This is a breathing tube going through the larynx. This is the back of the tongue. This is the primary tumor. You can see it's sort of a little bit more friable, bloody. But we're going to estimate that the tumor may be popping up there, but it may have some underlying extension here as well. So this patient's going to have a resection, and when they're done, this is what's left. This is the resection margin here around, and this is the underlying muscle underneath. This will fully heal with mucosa. This person will swallow. What I tell patients is the majority, not all, but the majority of TORS resections are just akin to a fairly larger or more significant tonsillectomy. There's risks of bleeding, and I won't underplay that. Just like there's risks of bleeding with tonsillectomy, there's risks with bleeding with this. But it is a highly effective way to remove these primary cancers. And long-term, the swallowing and speech outcomes in these patients is excellent. But they do have, for a few weeks after surgery, just like your tonsillectomy patients who are adults, 2 to 3 weeks where they don't like me very much because it hurts to swallow. Radiation therapy, though, also has advanced. We used to do conformal radiation therapy where beams would come from the outside, and the same sort of doing the half bath analogy, all the tissue would get exposed to radiation therapy from here through. We now have what's called IMRT, and almost every center has it now, intensity modulated radiation therapy. I describe this to patients as kind of like a topographical map. Here's that map. High dose area, medium dose area, low dose area. We're able to modulate how much radiation therapy somebody gets and protect the spinal cord. So you can see here, here's the spinal column being shielded. So they can now give higher dose therapy here, but then, like a topographical map, drop off the radiation doses fairly precipitously and not hurt innocent structures. That leads to less scatter, hopefully better salivation, although it's unclear whether that's the case, less toxicity, and improved swallowing, lower G-tube rates. Chemotherapy, we just don't know what it does yet. We know that it helps with sensitizing cancers to radiation therapy, but there is some evidence that immunotherapy or chemotherapy actually may control recurrent disease and maybe even helpful in primary disease. And it may be because it helps to stimulate an immunologic response to the cancer. In some cases, chemo may not be necessary. In some cases, it may potentially be a great monotherapy. We just don't know yet. I'd like to say and tout our UNC head and neck multidisciplinary group that we are truly a leader nationally in research in HPV-related oropharynx cancer. Dr. Chera, who's our lead head and neck radiation oncologist, has for the last many years been recognized nationally as the person leading the investigation of, can we de-escalate therapy? Can we lower radiation doses and still give people clinical cure and save and give them reduced morbidity? And you'll see from his trials so far, his survival rates and local control rates are very impressive, meaning that we can lower dose in the carefully selected patients, and these are patients who were non-smoker, proven P16 positive patients. They do very well even though we drop the dose down. And you may say, oh, so what? You dropped it from 70 to 60 gray. That matters because when you think about radiation toxicity, it starts here with lower doses, 20, 30, 40, 50, and all of a sudden there's a sharp rise from 50 to 70 in dose-related toxicities. So if you can drop down by 10 gray, that's a significant reduction in the toxicity. My colleague Dr. Weiss and I also have looked at the role of induction chemotherapy and immunotherapy. Dr. Weiss is our lead medical oncologist in head and neck cancer, and we were able to combine immunotherapy before surgery and have such an amazing response that of the patients, all of which would have needed radiation therapy before treatment, we were able to avoid radiation therapy in 75% of patients with, again, excellent long-term outcomes, doing immunotherapy followed by surgery. Again, trying to find a way to de-escalate therapy and improve people's quality of life, recognizing we have a younger population who will live longer. Nationally, people have caught scent of what we're doing, and if you now go to the national forums and national meetings, all of these centers are now doing similar trials to what we started years ago, doing robotic resection, reduced radiation therapy, induction immunotherapy, stereotactic radiation. Everyone's now on this bandwagon of, can we do more targeted, personalized, and lower dose therapy for these patients? It comes down to quality of life because we're reducing it because of that. Will lowering the radiation dose really cause a significant improvement in short-term and long-term quality of life? Will doing surgery and immunotherapy really reduce the downsides to treatment and improve quality of life, our short-term data would say that both of these regimens do improve quality of life. Which one does it better? I have no idea. We don't have a comparative trial randomized to tell you that. I also would say that within the medical field, we've learned nothing else over the century of medicine is that we think we know everything. We don't know what we don't know. And what we think works now may be the wrong thing 2 decades from now. All we can do is continue to investigate what are our options. We used to radiate children in their adenoids. We now know that's a bad idea. It may be that some of the theories that we are doing now, while effective in the short term, long term don't have good outcomes. So we need to follow these patients for many decades and make sure that we're doing the right thing by them. So what is the best option? The truth is, I don't know yet. I know that we have a lot of very good options with data going back about 5 to 10 years that says these patients are doing extremely well in their short term. What will happen 4 decades from now, I don't know, but I can say that we do have promise that there are ways to treat these patients and improve their quality of life over the historic quality of life after more intensive therapy. But in part of this, forget about just treatment, have focus on treatment. If we could do better detection and better prevention, that would be a significant improvement, because then we wouldn't have to worry about reducing morbidity because we wouldn't have to treat the cancer in the first place. So future direction should be continued trial investigation, better detection, and yes, let's talk about vaccinations briefly, and potential tumor vaccines. This is the virus. Here's E6, E7. Again, it blocks RB, which leads to overexpression of P16. That's our metric that we're using. But P16 is not specific. We talked about it. Now, in HPV-related cervical cancer, we have the Pap smear. Let me be clear about this. There are some devices on the market and rinses and lights and different gadgets that you'll see at your dental office screening for HPV. These are not useful at all. We do not have the equivalent of a Pap smear for oropharyngeal cancer. Saying somebody has on a swab HPV positivity, as we talked about earlier, does not mean they're going to develop cancer. In fact, their likelihood is significantly low. So there is no good screening test for who's going to get this cancer. We just have to continue to do mindful exams and mindful referrals when we have somebody at risk. So I would argue against going for all these different mucosal swabs or light or laser testing, because it's not going to be helpful in really screening who is at risk. P16 is a great marker. Like we said, it's not perfect. So can we do better than just P16? Is there something that we can find that's a more specific marker and maybe not only tells us whether there is cancer, but how well somebody does with that cancer? So Dr. Gulley is one of our pathologists here at UNC in 2010, showed that there is the ability potentially on blood testing in patients that we know have cancer that we might be able to measure their circulating tumor or cell-free DNA in the blood. Some of the virus gets shed, it gets in the blood. So this is not on the patient who just has an HPV infection. We're talking about somebody who's got a known cancer. We may have the ability to, during treatment or after treatment, in the near future, test somebody's blood to see if they have active DNA. Maybe that will be a more sensitive marker of recurrence than even symptoms or scans. So similar to the PSA for prostate cancer, we may, in the near future, have something that we can use as a marker test. We do not have anything prime time now that can do that. But there's active investigation by many individuals looking to see if we can develop a blood test for this particular type of cancer that we could use as a treatment screening tool and a response screening tool. The final thing on the slide is that we currently have a patent-pending RNA test that we might be able to offer patients when they're biopsied that could not only tell them if they truly have the disease and end this picture of is it P16 positive, is it really cancer or not. We may have a test that can do that, but also may be able to stratify into low-risk and high-risk populations. So here's a publication that we had recently in our literature. With the RNA testing we've developed, we were not only able to show that they were HPV P16 positive, but we were able, based on just the biopsy of the primary tumor, to predict whether the lymph node would be involved or not. So now we can not only assess whether the disease is actually there, but maybe be able to assess whether it spreads, whether it doesn't, whether it responds, whether it won't. And that, honestly, to me, from a global cancer perspective, is where I'd love to see cancer therapy going. Personalized therapy, where I could do a biopsy on a patient and be able to tell them not only what their potential side effects of treatment would be based on their own genetic makeup. Because let's be honest, not every cancer is the same, and we're all different people. And your response to cancer therapy is a combination of the host's makeup, immune system, and the cancer itself. And being able to know the interplay between those can help us figure out which therapy window to put them down. Will they do better with surgery or radiation therapy based on their biopsy and their genetic workup of the primary tumor? Will they have a higher rate of side effects or a lower rate? Will they have a just more aggressive tumor, so we need to add more therapy on? We're working on trying to get to that personalized level where we escalate therapy in people who need it, and we de-escalate therapy in people who don't, and we strategize patients into certain treatment algorithms based on the science of how their cancer is going to respond. Right now, our best is our induction trial we have here, where they get immunotherapy up front, surgery later. And those patients who have a great response to immunotherapy, they get surgery, they don't need radiation therapy. And the ones who still have residual disease, they're theoretically higher risk, they get more treatment. But can we do better than that? Can we know ahead of time for patients? So last is the role of counseling for patients, HPV. This should be multidisciplinary. This should be a treatment group, not a single doctor or surgeon making these decisions. It's very, very hard to have clinical equipoise, balance in your discussion. Because, as I said, we don't know what the right answer is. We have a lot of promising options, but we have to be honest with the patient that there are options, and we have to marry those options of treatment with those patients' priorities and their ideals. There are some people who are very radiation averse. There are some people who are very surgically averse. We should be thinking about that because they're the ones who are going to survive from treatment, and they need to be on board for it to go well. Role of family counseling. I alluded to this earlier. When we say that somebody has a HPV cancer, an STD-caused cancer, we need to educate people. It is not that the patient got this virus a day ago or a year ago. What we know is that the latency from viral infection to cancer formation can be as much as 2 to 3 decades or longer. So I have this conversation with people all the time. An HPV positive oropharynx cancer does not mean that your partner is being sleeping around or that there are fidelity issues in a relationship. It is likely an infection that was acquired many decades ago and wasn't even aware at the time. In addition, when I have a couple that's been together for 12 years, I get the question of, well, do I have to worry about transmitting it to my partner? The answer is, you've been together for 12 years. If you would have transmitted it, you probably would have done so by now. And realize that HPV does not mean you're going to get cancer. You have to have the host susceptibility and the right combination for it to happen. So there's no way for us to say that a partner who's been with somebody for 12 years all of a sudden now is going to have a higher rate of infecting their partner, and that that's going to lead to some cancer down the road. So it doesn't mean there's fidelity issues. And if you are a couple that's been together, then anything that could have been shared probably has.